Welcome, everybody. My name is Margot Farrell. I'm the Chief of Staff here at the Root Center for Advanced Recovery. We are so excited to welcome you to yet another community forum. For those of you who've never been to a community forum before, we usually do about 2 a year, and we do them on different mental health and addiction topics that are really kind of at the forefront of what's being discussed. Right now, harm reduction, we know, is a very, very big topic. It is something that is a hot button issue. We here at Root Center are strong believers in harm reduction. Actually, one of our panelists who you'll hear from hosts a day at our Torrington Clinic, and we're looking into implementing more of that across some of our other clinics as well, because we know that it really does just such wonderful help for our patients and the folks that we serve. So we're really excited tonight. We're talking about navigating public and political perceptions, because we know a lot of this is not just the fight that we fight, but also what's happening up at the Capitol level and things like that. Laws and rules that are in place that we have to fight and battle against. So there's a lot of different voices to bring some expertise on the topic forward tonight. So I'm really excited for you all to get to hear from these folks. Just one note, if your phone's not on silent, please put it on silent. We are recording this, so folks who couldn't be here tonight can watch virtually. We also have folks who are virtual in the back. That's what that Zoom presentation is behind you. If you need a restroom, it is out the door to the left, right down the hall, and the emergency exit is out the door and to the right. Without further ado, we're going to get started. Keep in mind, we have one more panelist who's coming to us from Philly, and the roads have been a nightmare today, so she's running a little bit behind, but she will be joining. But we're going to start with who we have here tonight. We'll go right down on the list so you can start us off. Introduce yourself, where you come from, and why you wanted to be a part of this forum tonight.
My name is Sue Clark-Levin. I work in Hartford. I've been there about 17 years with AIDS Connecticut, which changed the name to Advancing Connecticut Together. And I'm under the Drug User Health Connecticut Harm Reduction Center. I'm under that part of they do a lot of HIV, Hep C housing, but I do the drug user health. That's what the name of the grant is. We do a needle exchange program. That's what I do.
Hi, I'm Liz Evans. I work in Bridgeport at Liberation Programs. I've been involved in work with active drug users for about 35 years, starting in Canada. I was involved in providing low barrier services to people living in a very densely populated low-income community, which was like a kind of Skid Row area. My background is nursing, so I ended up running this hotel, bringing supports into folks that were homeless and drug users, and then kind of learning really from the community all about their lives. And over a period of about 25 years, we grew a number of different programs and developed interventions targeting people who were still active in their drug use, all of which became later to be termed harm reduction. We weren't really coming at it from that perspective. We were just working with people from a pragmatic kind of viewpoint. One of the programs we started was the supervised injection site, which opened over 20 years ago now in Canada. Since then, I have been working, I did a bunch of international work for a couple of years. Then I was working in New York, and now I'm in Quebec.
Hi, everyone. My name is Ben Florsheim. I am the mayor of Middletown, Connecticut. I have served in that role since 2019, and we just recently, a couple months ago, opened the first Root Center location. Actually, not the first Root Center location, but the first methadone clinic, the first public-facing medically assisted treatment clinic in Middletown's history in Middlesex County, and it's a Root Center clinic. And I'm excited to be here to help talk about how that came about. I'm excited, frankly, to hear from some of the folks up here about strategies, as well as folks at the Root Center about how things are going and how we can continue to be community partners. We've been really grateful to have, even before the clinic opened, going back the last few years, we've formed, I think, a really easy partnership between my office and City Hall, as well as our health department and our and our community in general, and Root Center. Root has been present for community events. They have helped us refocus our efforts as a community around recovery, and we're just really fortunate to have them in town. I feel fortunate to be here, and I'm looking forward to the conversation.
My name is Cameron Breen. I work as harm reduction coordinator for McCall Behavioral Health Network, and I coordinate harm reduction services for the Litchfield County Opiate Task Force. Previous to that, I worked couple of years with Waterbury Health Department's overdose response team, responding to all overdose calls with the Waterbury Police Department and connecting those individuals to services and support. From there, started this role with the Litchfield County Opioid Task Force, and for about the last year and a half, we have been facilitating a harm reduction site, syringe service, safer smoking supplies, all that kind of stuff in the Root Center Clinic in Torrington, serving kind of the entire population of Litchfield County. So thank you for having me here.
Hi, everyone. My name is Ben Bazin. I'm in my second, soon to be third year of medical residency training in psychiatry at the University of Connecticut, up in Farmington primarily. I have a particular interest in addiction. I've been fortunate to have some exposure to harm reduction ideas and practices in medical school and residency, and I'm excited to be here and hear from these other people who have a lot more experience than me.
Hi, I'm Sarita Rao. I'm an addiction psychiatrist. I'm the residency training director for the psychiatry residency program at University of Connecticut at UConn Health. Thank you for inviting me. We're excited to be here.
Awesome. Well, thank you so much to all of our panelists for being here tonight. I think to start things off, this might not work, but I have a loud, proud voice, so we're okay. Cameron, you do a harm reduction day at our Torrington Clinic. I'm gonna just go off that one. You do a harm reduction day at our Torrington Clinic on Fridays, and that's been really well received. I think to start things off, maybe paint the picture for folks who are not as familiar with what harm reduction is. Tell them a little bit about what you do, kind of set the scene for what a typical day looks like when you do come to our Torrington Clinic on Fridays.
Sure. So about a year and a half ago, we started the site with, I'm not sure if Dana's still here, but I would like to thank her with Dana's help of getting a harm reduction site into the methadone program at Torrington. And when we come in on a weekly basis, for a period of time, we only kind of covered the hours of like 8:30 to 10:30, but we realized that, you know, a lot of people come into the methadone clinic very, very early before they go to work to, you know, later on during the day. And we didn't want to hit, you know, just one piece of the folks who come into the clinic every day. We wanted to make sure that everybody had access to the services or knew that the services were there. So shortly after starting, we began covering the hours of, you know, the entire time that they dose, 5:30 in the morning till 10:30 when dosing completes. And normally I'll leave the clinic after having conversations with folks around 11 a.m. But we have what is called a rover, and we bring in through Connecticut Harm Reduction Alliance, and we bring in kind of this mobile toolbox that carries syringes of all shapes and sizes, you know, different gauges, different lengths for the different, you know, various ways that people ingest or inject their drugs. We have sharps containers, we have naloxone, we have tourniquets, we have supplies for wound care, we have supplies for xylazine related wounds. We have safer smoking tools for, you know, that cover hammer pipes to bubble pipes to pipes for using crack cocaine or smoking crack cocaine. And I think really all of those things being said, what we offer is a service to individuals who, regardless of where they are with their part of their journey, you know, we offer respect and dignity and the opportunity for, you know, healthier interventions and treating them like human beings. And the relationships that I've been able to build with the folks that we see there on, you know, a weekly basis has been amazing. And some of the things that they've said to me, you know, over the period of the last year and a half, like when collecting some qualitative data and doing some surveys of the folks that we are working with, just one like quote from a person sticks out in my mind, which was, you know, that they felt more at home and at peace with themselves as a human being since engaging with our services. You know, we don't turn anyone away. We don't necessarily offer them one option for bettering their lives. We offer them, like I said, respect and dignity, and allowing them the autonomy in their own lives to make those decisions. And even over that course of time, I've had discussions with folks and seen a lot of folks start to minimize their use and look at, you know, gaining more stability in their life. And we are there, like I said, we probably see roughly 35 to 40 people per week at that site during those hours. And, you know, I know all of them by name and I absolutely love being able to still be a part of front-facing services that, you know, engage with folks exactly where they are.
You're really on the front lines and you have that firsthand experience and can speak to how folks respond once they've kind of gotten to know you and they're coming to the program. So that's really the humanistic impact. Let's talk a little bit more about how, you know, shifting into that perception part of what we're talking about. Liz, you mentioned that you've done a lot of work in Canada, and I know when you compare, the United States doesn't always seem like we're necessarily measuring up with other countries in their progression in terms of how they're looking at addiction medicine or recovery. Speak a little bit about how you were able to take what you maybe implemented and saw in Canada and bring it here, and how maybe those tides are changing a little bit.
Yeah, thanks. Well, first, thank you for inviting me to join you. It's always humbling as a Canadian to come and try and explain the differences between two very distinct cultures with a very different history. But I have now lived in New York for 8 years, so I feel like I'm much closer to understanding what those differences are based on. And there, by no means have I brought everything I know here, like, because it's a very different environment, right? So I've brought, I think, in terms of how I've worked both in New York and now in Connecticut, just a set of principles and beliefs that have been born out of experience from working with people who use drugs, from the vantage point that, you know, when I started in this work, like many of you, you know, you just want people to get well and do well. Nobody wants people not to be doing well. I used to go home and cry all the time. I was working with people whose lives were falling apart right in front of me, and it looked like they were about to drop dead, and I felt so hopeless and so sad all the time. And I would literally approach people and be like, don't you want to go to detox? Can I get you into treatment? And it was like a tidal wave of people that would be learn very quickly that I wanted to hear them say, yes, I do. And I'd be like, great, well, let's make some phone calls. Let's get you in. And lo and behold, they wouldn't show up, or they weren't there the next day when I had convinced them that's what they wanted, you know? So after being in that environment for a long time, I realized I'm just parroting to people. People are just parroting to me what they think I want to know, right? Then eventually I had this woman, Shannon, who I worked with for a really long time. And I sat down one day and I was like, Shannon, you don't want any of the things like you keep telling me you want. What do you want? She's like, I want a pair of new curtains in my room. And I'm like, oh, I can do that. So I was like, great, give me something practical that I can actually do that you really want. And that's how I learned that a lot of the nuancing around this stuff is really what our stuff is. It was what my stuff was. And so the most important lesson I learned that I try to work with staff in this space around is whatever your story is about your recovery in this environment, right? A lot of people who work in this environment have got their own recovery story. Whatever your story is about your childhood, your pain, your life, your sense of identity, and how you feel about the people that you're working with interacts, right? So the second you look at someone, you think, my hope for you is to no longer use substances. That's actually about you. You don't know what that person's story is. You don't know what their life's been like. You don't know, have they been sexually molested for 15 years? Were they, you know, I worked with a guy the other day who tried to hang himself. Like, the stories are endless. We all know them. They're awful and traumatic and often lengthy. And I don't think anyone in this room thinks we can fix addiction quickly. It's no one doesn't want to. No one doesn't want people to not suffer, not have pain, not die. I mean, I think that is the common denominator that links people who work in recovery and work in harm reduction. We know like suffering and pain. People who come from the harm reduction world are saying, we're working with the people that have been left out. They're not in. The recovery world is working with the people that are in. They passed the gate, they got into something, a treatment program, an inpatient program, an IOP, a methadone program. The people in the harm reduction services haven't gotten in yet. And they're gonna be at much greater risk of dying because of that. So that's it, really. There's no distinction. All the love you feel for the people that you're working with, all the compassion you feel and the hope that you feel when you're working in the recovery world for people that you're working with, people in the harm reduction world feel too, but the people they're working with are still using. That's it, really. Like, in my mind, it's not that different. The only other difference I would say that I like to emphasize is there is hope in little things when you're working with people who are still using. We don't think in harm reduction language that the only positive thing that can happen with somebody is that they become sober. I can think by giving Shannon curtains and working with her every day for 2 years to do whatever little thing it is that she needs in her life, that's going to make her feel maybe seen, maybe loved, maybe cared about. And those things impact the way people relate to drugs. They influence the relationship people have with drugs. So when you think about it that way, the opportunities to do good things with people while they're still using really open up, which is why drop-in programs where you're providing clean supplies and just treating people nicely and not giving them this message of you're failing, you haven't become sober yet, is such a positive, hopeful approach, as opposed to what sometimes people think is, oh, you're giving up on people because you're allowing them to continue to use. So my view is it's the exact opposite. It's like, I'm looking at you saying where you are right now is where you are right now. That's it. No judgment. It's not a celebration of where you are. It's not, yay, you're using drugs. And it's not a, oh, you're a terrible person you're using. It's neutral. It's like, oh, this is who you are right now. And by seeing that person and encouraging an honest dynamic and an honest relationship, then the idea is the person can then have a real authentic connection. Anyway, I really didn't answer the question at all. I think I totally went all. That's my philosophy. Sorry.
And I think using that philosophy that you have, that passion that you have, you also have that unique perspective of having a different country's background and approach to something that you can bring here, as this is a conversation that's starting to pick up speed in the United States.
Definitely.
So how does that compare? How do we kind of map up with the Canadian practices?
Our conversation, or at least the one I started in our city back in 1991, has been going on for like over 35 years, right? So there's a long history of having had the conversation. So a whole lot of services evolved around what we called a low barrier approach. So housing where people can be active users and live in housing with services embedded in the social housing programs, like low barrier drinking programs, low barrier safer supply programs. Methadone is very easy to get through your family doctor or through a local pharmacy. There's none of this regulation around how you go to a clinic and get it. Like, it's just a very different environment, very different setting. However, the conversation to be able to introduce services that included low barrier services and harm reduction services had as much difficulty as the conversation here does. It wasn't like, oh, all of a sudden everybody was all on board, right? Like, it was a struggle. It required a lot of education. It required extensive community meetings. Our mayor we developed a strategy called the 4 pillars, where it was harm reduction, prevention, treatment, and enforcement. So we had 4 pillars, so 4 speakers at a table. We'd go on these roving trips. We'd go all around the province and the city, representing what was going to be the new city policy and drugs, which was the 4-pillar policy. But we had to figure out how to introduce harm reduction into the existing pillars. And it meant having people in prevention, treatment, and enforcement on board. So that was like a whole 2-year thing. You know, there was much controversy. When we opened the injection site, there was only about a 20% approval rating. When we had opened, after a lot of public education, a lot of advocacy, and then research after it opened, 3 years into it, we had a 76% approval rating from the city residents. Like, it was massive change, right? Part of it was people realized it was working and they didn't have to be scared of it. A lot of it was people just shifted in their perspective when they realized the sky didn't fall and it was doing what it set out to do, which is prevent people from dying. And that was it, you know? So I come here and I have conversations with people in Connecticut that are like the conversations I had like 35 years ago in Vancouver. And I'm just like, oh, like, so part of me feels like this is like starting all over again. But another part of me is like, no, you know, John Oliver's out there talking about stuff, but like, there's some stuff happening. I feel that generally in the treatment and recovery world, there's been this acknowledgement that we've forgotten this whole big piece called harm reduction. And everybody and their dog is scrambling to try and figure out how to do it and what does it look like and what does it mean for us as an agency. And these conversations are happening, which are incredibly important. And this is where change happens. I have spoken at 18,000 meetings in my lifetime. I'm really old and I wish I had counted actually how many I have spoken at, but I've never been at one that didn't matter. Like, whether it's 3 people to 30 people, 300 people, like, this is how change happens. People have to feel in their heart and soul that this makes sense for them. And then they go out into their work and their world and they think about things differently, right? But then politicians will take their cues from the public and go, oh, well, if they care, then I gotta care. But the ground is where the change happens, in my opinion, and that's what has to happen in Connecticut. We need a lot more of these conversations to put pressure on our leaders to understand that it's what we want. It's a direction we want to move in so that they can't avoid it. That was the same in Canada, years and years and years of that.
Well, luckily, we have someone representing the
Yeah.
political side of it, so we'll put him in the hot seat here. Then when you hear these types of things, and you yourself, for those who don't know, we had quite the legal battle in Middletown. So we just opened up our clinic that Ben mentioned at the beginning of the forum. But that was met with a lot of resistance, and Ben was a huge proponent in going to bat for us and fighting for us and knowing that this was discriminatory, that you could not have methadone clinic within Middlesex County. So Ben is definitely, this is a key reason why we wanted him on this panel, was that Ben has had experience in his tenure with working against discrimination for those who suffer from mental health or addiction issues, or both. And so we wanted to see, what is your take when you hear about the harm reduction conversation, when you hear these folks saying this, and obviously how big of a proponent you are to get recovery services in your community?
Yeah. Well, thank you, and thank you for the kind words. And I think that the bottom line for me is I think that we are starting to see at least in Middletown, at least from my perspective, what you probably were already seeing in Vancouver 35 years ago, which is that people react to the fact that it works with respect to harm recovery and with respect to these services being available. And so much over the course of my term. So I took office in November of 2019, just before the pandemic, and the entire, all of our lives have been defined by the impact of that event still in so many ways. And part of that was that our approach to healthcare in general had to be completely reimagined. And also we were seeing the beginnings of what has been a very persistent kind of ongoing mental health crisis for so many of our residents. And in many ways, I think taking office at a time of upheaval was a positive thing, because we had to accept that the world was changing in really dramatic ways. And of course, it was against that backdrop that this conversation between the city of Middletown and the Root Center began. Stephen Zuckerman reached out, and I sat down with him and our then Director of Economic Development very early in my term. It may have even been before COVID set in. Yeah, because it was in the office. It must have been.
You were in office about a day when we approached you.
Yeah. So they had been watching. They had been watching and waiting. And I come to this issue not, unlike I think many. I think everybody knows somebody has family members who have been affected by this disease. And I had the privilege of growing up in and around, and as the son of mental health professionals, and it had a lot of exposure to the notion that treatment and recovery was possible in a way that I took for granted until I got involved in politics. And but I at the same time had the opportunity before I was mayor to work for Senator Chris Murphy for a number of years, and doing that towards the beginning of his Senate career. And when he was really focused on authoring what eventually was successful mental health reform legislation, and sat in a lot of rooms like this one, having conversations with professionals about all the things that don't work about our federal administration and our administration in general of mental health services. The fact that parity doesn't really exist in reality the way that it's supposed to in statute, the lack of coordination of I could go on the reimbursement rates. I don't need to get into it because I think we all are familiar with it. The takeaway again, though, was that the recovery is possible and in fact likely, right? It is the likeliest outcome if the services can be delivered in the right way, meaning affordably, meaning in a way that is accessible to people. And again, I do think for all of our faults, for all of our land of steady habits challenges, Connecticut has been in many ways a leader in community-based mental health services, and has also had just these weird quirks that have made service delivery a lot more challenging than it is in other parts of the country, notwithstanding countries that have real healthcare systems. And the challenge in Middletown was that we had a zoning code that prohibited methadone clinics as just a general use, which is obviously not, if that had ever been challenged, it would have been overturned. The Root Center approached us, said, we are interested in opening a clinic in the community because we have a lot of patients who live in your community, and obviously the need is unfortunately continuing to go in the wrong direction in terms of addiction rates, and obviously treatment has to be made more accessible. And right now as Margot said, there was not a medically assisted treatment clinic available anywhere in Middlesex County. And if it was going to be anywhere, it needed to be in Middletown. We were fortunate in that, myself and our economic development director and folks who were on the Planning and Zoning Commission at the time did understand the need to change that code. And we changed that code towards the very beginning of my term with very little problem and with very little fanfare. The problem became when it actually became a reality, when it went from a notion to an actual proposal for opening a clinic at a particular location in a particular neighborhood with particular neighbors who have their particular concerns. And many of those concerns were expressed as concerns about traffic and impact on the local economy. Some well-placed concerns, frankly, about traffic that have a lot more to do with the design of the road, which we're also trying to address, than with Root Center's location, which was selected because it made sense for the clientele that they're trying to serve. And again, the thing that we kept coming back to over and over again, I'm looking at Stephen, is that we have a lot of residents who were using these services, and in order to do that they had to go take 45-minute to an hour and a half round trips to clinics in New Britain or Hartford before they start their day. And we're talking about harm reduction primarily tonight, which is such an important tool, I believe, for making treatment, again, meeting people where they are, making treatment accessible to people, and allowing them the opportunity to see the recovery can work. But on the other end of the spectrum, you have somebody who is in all likelihood working full-time, right? Has a lot of probably other mental health challenges that they are dealing with and other challenges in their life they're dealing with. Having to do this daily treatment, right? It's not a harm reduction, overdose prevention conversation. It's daily commitment to staying in treatment. That's a difficult thing when transportation is difficult, and when you don't have a clinic in your own community. And so we create that huge obstacle for people who are seeking recovery and who are committed to recovery. And the concerns that you generally hear about when these clinics are proposed in different communities from people who are worried about the impact that it's going to have, who don't want to see that treatment use in their town. It's all those people are the ones who are also most sort of disgusted. I'm sorry to use the word, but that is the word, by visible drug use, by the knowledge that drug use exists, by the knowledge that mental health challenges exist. And so I guess another way to put that is the complaints that I hear from people who see visibly that people are using drugs or are drinking in certain neighborhoods of Middletown are often going to be the same ones who are opposing the existence of any kind of effort to treat those folks. And I think that sometimes that comes from a lack of lived experience. It comes from a lack of maybe of empathy. But I think it, in many cases, comes from a lack of faith that treatment is possible and the recovery is possible. Oftentimes because people who have themselves or their family members been failed by a system that doesn't work. And So it's a very challenging landscape for this. But again, I think I'm fortunate to be in a community where I do stand on the shoulders of a lot of giants, both who have been elected to office and who have started mental health organizations in the community. We are unique in the state, and that Connecticut Valley Hospital is the last state-operated mental institution facility in Connecticut, and is in many ways a unique institution in the country. That has shaped a really unique relationship that we have had with mental health, I think, in this community. When the Root Center was proposed, the Planning and Zoning Commission actually voted 5-4 in favor of the proposal, but because of a weird quirk in our charter, they required a supermajority to have it considered an approval. So that meant that even though there were 5 members of the Planning and Zoning Commission who voted for it, the proposal did not pass, and that led us down a path of lawsuit between the Root Center and the city of Middletown, where I was in the really difficult position of defending a lawsuit based on a decision that had been made by a different commission that I had no power over. And so what I tried to do was tell people everything that I've just said, do my best to use the platform and the role to share with people why I thought that this would work. And I'm going to stop talking because I've been talking for a long time, but I also want to, I would love to talk about how there's been some amazing integration with harm reduction efforts in the community that again, just show that it's possible to fix this problem.
Well, we certainly appreciate your help with everything, and I can say at the Pride Parade, many of your residents were telling us, Root Center, we're so glad you're here, we're so glad you're here. So it was a really positive response to a great event on Saturday.
Mark, I see one thing I just want to say for Mayor Florsheim, that site would have never happened without your involvement and your engagement, never. So without your support, we would not even be talking about Washington Street today. So.
It certainly is a partnership that we're over the moon about.
The best asset in politics is to just be in the right place at the right time, and I'm glad that I was.
Well, we have Dr. Utter who joined us, so we went around and everybody introduced themselves, so what they do and why they're excited to be on the panel. So why don't you go ahead, and she's fresh from Philly, so.
I apologize for the delay. I drove up from Philly and it was a lot longer than we expected. But my name's Dr. Jerry Lynn Utter. I'm a licensed clinical psychologist from Philly, specifically the Kensington section of Philadelphia is where I was born and raised. So I do a lot of work, helping folks that struggle with co-occurring mental health concerns. So somebody that has like opioid use disorder in conjunction with like PTSD or depression, they're the folks that I really like to work with. I do a lot of criminal justice-based work. So I spend a lot of time hanging out in juvenile detention and in the adult system, conducting psych evals for the courts. And my role is to really help people get out of that system of constantly being reincarcerated for things that are technical offenses, like a positive urine, or things of that nature. I advocate a lot for people in the criminal justice system, and any group of people that anybody has something negative to say about, they're my people. And I do anything I can to support them and to help them when they're ready. And if they become ready for treatment, I'm the person that's there or tries to be there to be one of the many folks that help them out. So thanks for having me.
Let's switch and go into the medical side of things, because we know that harm reduction works. We know it is evidence-based, it is science-backed. Tell people from a medical perspective why it works, why we do see the positive impact. So, you can't argue with science.
Sure. I think there's a lot that can be said there, yeah, but I think it starts with just realizing that it's still important what happens to someone medically and just in their life in general, even if they're still using drugs, right? This is like the basic idea we've been talking about. But we see all sorts of complications of substance use, really severe life-threatening ones. And I think what remains to be realized by a lot of doctors even, frankly, is that those things are preventable even if someone continues using substances. And so I think kind of spreading that idea around, and that is part of our job, to help prevent those complications, whether that's preventing, contraction of diseases like HIV or hepatitis C, through things like clean needle exchanges and providing resources like that. I think there's a lot of work to be done in helping medical personnel, including doctors, realize that that's part of their job is to, your job doesn't end, we have enough, trouble, even getting to the point of offering everyone appropriate treatment for substance use disorders, like making sure everyone who would benefit from like Suboxone or methadone is offered that, like that's a big struggle still. But I think realizing that even beyond that, if they're not in a place where they're interested in those medications or they're not ready to stop using, our job is still not done, Yeah, I don't have a lot of specifics to name about the benefits, but I think it's also very intuitive that the benefits are there. I mean, obviously, if someone has access to clean needles, that's going to reduce their rate of infection with these potentially lethal complications. So, I don't think anyone's challenging that, but it's getting people to even think that that is important and not stop the conversation earlier is, I think, one of the crucial
They
things.
might not be challenging that per se, but what they're challenging or the comment that you hear a lot is you're enabling, you're encouraging, you're helping. And I know I chatted with Cameron about this when I came and did a segment with him in Torrington, and that's, a term that gets thrown out a lot. And someone who couldn't be here tonight, but we have a podcast if you guys are interested, Sarah Laurel with Savage Sisters in Kensington, in Philadelphia. That was a comment I asked her in the interviews. What do you do when someone looks at you and says you're enabling? Sarita, how do you come back at that with the science side of things to say, well, no, this is actually what we're doing?
That's a really good point. So as an addiction psychiatrist and as a physician, I actually have not had anyone run up to me and say that needle exchange or distributing naloxone or teaching people how to bleach their needles or get safer, whether how to use crack cocaine or whatever else is enabling. And I think maybe they haven't said it because I am a physician, so maybe they're figured, okay, this person. But the reality is, I think, people have a lot of sort of moral judgments about people who suffer from, any kind of addictive illness, any kind of substance use disorder, whether it's alcohol, opioids, whatever. But if you look at it from a public health perspective and also from an individual perspective, like from a public health perspective, let's say you are somebody that really feels that somebody who is actively using drugs deserves everything that happens to them, right? Bad things, like you believe that they brought it on themselves. So if they get HIV or Hep C or they pass away from it, that maybe that person believes it's okay. But if you look at it from a societal perspective, that's what I would say to such a person. Like if they don't have any sympathy in their heart for the person who's suffering, I would just say, but what about the taxpayer dollars? Like, let's say somebody becomes Hep C positive. These Hep C medications cost a fortune right now. And so, or somebody becomes HIV positive. I mean, their life is forever changed. They've now gotten a chronic illness. And at the same time, you're also sort of taxing the healthcare system and the limited number of dollars that there is. So that's a different route to take rather than saying every person deserves to live. Every person does deserve to live. You're not going to hear from us as doctors that people don't deserve to live, because that's our whole thing, is we try to keep people alive and from our perspective, one of the big things we want to do, it's part of our training, is reducing mortality and morbidity. Basically, those are fancy words to say we try to prevent people from dying, which is the mortality, and the morbidity is like we try to prevent them from getting sick with anything. Or if they did get sick, we try to make sure that the illness causes the least amount of harm to them. Like if somebody has bronchitis, we would want that person not to progress to some kind of pneumonia where they need to be admitted to the ICU and need IV drugs, right? So I feel like these are just basic things. If someone's dead, they can't enter recovery. So then they are right? They have to be alive to participate in any kind of treatment. So I don't see how people can argue with that, but I do know that in society, I have not had anyone come up to me and say, you know, harm reduction is bad or people should just be allowed to die, but they know I'm an addiction psychiatrist, so I don't think they're gonna say that to me, but I feel like even if they do believe that, then, you know, what about all the money that's gonna be spent by the system? Like, if they don't have insurance, then our tax dollars will still be spending the money. When they come to the emergency room and they're very sick, they're still going to be treated. And that treatment, you know, financially is passed along to the people who have private insurance. And also from a public health perspective, you want to improve the general health of the population. You don't want a large number of people that have infectious diseases who are now going to spread it to other people who may not be using drugs because they are, you know, their romantic partners or whatever else it might be. Also, I mean, I would just appeal to their humanity and say, does somebody really deserve to become like Hep C positive or HIV positive for life because they have genetically inherited, you know, vulnerability to substance use disorders? But even as Ben said, you know, as Dr. Basin said, like even within our, to be completely honest, even if you think of healthcare professionals, doctors, nurses, you know, everyone else, it's like there is still a lot of stigma even within the healthcare world, you know, against people who use drugs. I feel like they're kind of a, you know, when you talk about groups that suffer from prejudice, I think people who have substance use disorders suffer from bias in society, but also when they come into a hospital sometimes.
Absolutely. And for an anecdote perspective, I do know of a physician who works actually in Philadelphia and had heard this physician talking about cases that were coming into the emergency room. And right now xylazine is a huge problem. And they are now just they're stopping basically further treatments on the folks who are coming in and just doing wound care and sending them out. And one of the comments was, I wish this person would die. Why are they coming in? They're just utilizing our services. I'm already so busy. I have other caseloads. And the thought is that part of this is a choice. And it's interesting to hear you say that as a medical provider, that folks aren't saying that to you when there are medical providers themselves who shockingly are the ones saying it as well. And Sue, we'll come to you now because you do a lot with
You know,
education.
I was just going.
Yeah, no, so go off on that, yeah.
A lot of, at least a third of our clients, if not more, have terrible xylazine wounds that we are basically treating, and we're not medical staff. It's just that they will not go to the hospital. Well, there are a few that have gone and have been there for weeks or months sometimes on IV antibiotics. And then we're sent home with antibiotics but just to get someone to go is so hard, it's so rare, and it's so sad. Because it's just, I even show them pictures of amputations that other clients, you know, let me take pictures of their hands amputated or incredible wounds, I mean, through to the bone. The xylazine is just, it's like, we thought fentanyl was the worst thing that could happen, and not that it's, of course, it's terrible, but these xylazine wounds are just terrible. And then, of course, there's the latest MET.
Metamidine.
Yep, I just started reading about that. Toronto, Philadelphia, and
Chicago, London.
Chicago, there you go.
Yeah.
Yeah, so I know that will be up here.
Yeah.
But what I was gonna say was, first we try to treat it ourselves. I mean, I don't know that we have all the zero form pads, we have the equipment, and we've read a lot about it, studied it. A lot of them are reversed by early treatment. But there is a certain point when they stop, you know, listen or stop doing, you know, what we say, then they start getting worse. And then sometimes they end up having to go because they literally can't walk. Their legs are so bad. For some reason, it's the knee down to the ankle. I mean, just the whole area. But what I was going to say about the attitude, talking to people who worry about the bottom line financially, I hear the idea that HIV, I was in the HIV Hep C world before this, the harm reduction for many years. And I remember the statistic way back, 49% of IV drug users, HIV positive 49% were from IV drug use, way back. As the years went on, I think it's down to like 9% now. So that's a very important statistic to show a medical provider or someone that's worried about money. The idea of the crack safer smoking kits, the idea of the glass, cutting the lip. So there we've got like crack can also be a problem with hep C, you know, bloodborne diseases, and that's, you know, that's a big one. So there's a lot of arguments for harm reduction. And I used to think the best argument was wait till it happens to your, you know, nephew or your sister or brother. But then I realized some people, I hate they have bias against their sister or brother. It's not that because and that, oh my God. I don't know
Often
what-
due to their addiction.
Yes, and then I thought, oh my God, that's not necessarily, but basically, the way I look at it is we do everything we can to support them and keep them safe and healthy. Because if we weren't there tomorrow, they are not gonna stop. That's what people don't realize. Oh, well, if you didn't give them everything, you give them clean meals, you give them, well, no, if we weren't there, they're still good. That's not gonna stop it. So that's the part, the further on that they're not really thinking of. But it's very rewarding because many do, as we all know, do come back a month later, a year later, and doing very well in the various methadone, Suboxone, AA. Some never go to treatment. That was the other thing. I thought everybody went to treatment. You had to go to treatment, and then you went to methadone. No, the majority do not go to treatment, and they somehow find recovery. And there's just so many fascinating things that you find out as the years go on. Because I thought my job was, in the very beginning, oh, I think you need to go to treatment. That will just, you know, and that lasted a few weeks when I realized that's not how it works. So I just think it's a wonderful field. And if somebody will really engage with you and listen to what you do and yeah, how you help and how it helps them. And then that together with the idea that, yes, everyone does know someone now. They may not like them, they may not.
Well, and I like what you touched on was that, you know, that if you didn't give them the needles, that they would have stopped. And it's like,
Right.
no, they're gonna find a way to do it anyways, it just might not be safe. And Jerry, you talked about folks coming to you when they're ready and saying that when you're ready comment. And that looks different for folks. And what is your ready? Is it you want to maybe use less of a substance? Do you want to stop altogether? It's a different thing for everybody. So maybe talk about some of the folks that you've seen and also, you know, you had lived experience with your parents having, then she also did a podcast for us, so go watch that. Your parents struggling as you were growing up and in that very hard hit area in Philadelphia. So you know all about what it is to see somebody if and when they're ready.
Yeah, that took about 20 years to figure that out. You can crack open any book you want, go to any course you want, and get any type of education you want. But when it comes to meeting somebody where they are, that takes a lot of experience and being out there. So I never wanted to be a psychologist, side note. That was like never something I wanted to do because of my own trauma and my parents. I just gravitated towards the field and it kind of sucked me in like a magnet. But forcing somebody into recovery or into treatment always ends up really upsetting and creating resentment for the family member or for the loved one. I don't care if you have all the resources and money in the world or you don't have two nickels to rub together. If somebody wants to get help, they're going to get help and they're going to take your help when they're ready. I don't like when people try to guilt somebody into treatment and say, oh, well, you have kids, you know, or your husband or your partner, they love you, or, you know, you're in legal trouble. Legal trouble, losing custody of your kids. Like I was on the other end of that where I had DHS in my house, like as a kid. And I was on the other end of, you know, rehab after rehab and near-death experiences and drug-induced psychosis. And every time, you know, my mom would mess up and be like, this is going to be the time. This is the time because she lost her shit for a whole, you know, 30 days, didn't know where she was or who she was. And she was on the psych unit. This is going to be it because she lost custody of my younger sister. Like this is her bottom. And and it's not, you know, you can't predict when somebody's going to be ready. You can't guilt them. It has nothing to do with whether or not they love you or not, because they love you. even though they're not acting like it, if they're your love, believe me, they love you, but for you to put on the line and say, if you love me, you'll go to treatment, then you're gonna think that they hate your guts because it has nothing to do with you. It's not personal to you. Somebody's gonna get help when they're ready to get help. And it doesn't matter if God or Jesus or whoever they worship or comes and says, will you please stop? They'll go. They might go to detox for 6 days. They'll go to detox for 6 days and get better because they're a little tired from hustling. So they'll go for 6 days. But then when you turn around and you say, hey, you wanna go on the rehab side for the other 21 days that your Medicaid will pay for? Maybe they'll go begrudgingly if it's gonna keep their PO off their back, or maybe a little bit, but they're gonna AMA, they're going to leave when it's recommended that they don't because they're not ready. So my advice to somebody, whether you're a professional or whether you're a loved one, is you have to meet them where they are. So how did I learn? My mom would be down on the avenue. You know, I knew she was getting high. I knew she was doing her thing, or I had patients that are down and they're doing their thing. And I did that. I would drive down Kensington Avenue at 2 o'clock in the morning in crack houses and say, come on, mom, like, let's meet. That didn't work, right? So how did I manage that myself? After many, many years, I said to my mom after the 100th rehab, and I say the same thing to patients, when you're ready, I'm here. You could call me at 3 o'clock in the morning. When you're ready, I'm here. But listen, we're gonna go, I'll buy you a pack of cigarettes first, fine, but we're gonna go right from the avenue to the rehab. We're not taking a shower. We're not gonna talk about, I gotta pay the electric bill. They have great stories to tell you about why they wanna wait longer. I don't care about the stories. Mom, when you're ready, you call me and I will pick you up and we will go. And I've done that. And there's been times where she's gone and she stayed in the program and she's had, times when she has been sustained in her recovery. Same thing with patients. But I had to get my own therapy and I had to learn and understand that I couldn't take that personal. Because if I took that personal, I would really think truly that my parents didn't give a shit about me or that they didn't love me or my partner didn't love me. So that's kind of what I learned from it. And as a clinician, I kept that same thing because we take it personal. I don't care. Sometimes you get, oh, they were doing so good for so long. It has nothing to do with you.
Yeah.
It's not about you. Like you did your job. They were somebody that you were somebody they trusted. You were somebody they vibed with, but their relapse has nothing to do with you, just like you can't take credit for their recovery because their recovery is theirs. So all those words are great to say, but I struggle to this day to I have to remind myself of that and I have to check myself because it's a hard field to be in. And like you were saying, like there's times when you feel good, like when somebody's doing good, you're like, you just get happy because you're
Yeah,
like,
you need that once in a
You
while to
do.
keep you going, because there's so many,
there's so many
Oh.
hardships, right? Or
yes.
a lot of death.
yes.
So that's that. And like transfer addiction's another thing that I just want people to have on their radar because somebody may not be shooting dope anymore, right? They may not be doing fentanyl or xylazine. But what I've also seen a lot, and I don't know if folks up here have, is the transfer addiction. Well, I beat that. I'm not putting a needle in my arm, but you're drinking. You're drinking. Like, what are we doing
Gambling,
here?
sex.
Yeah. So
That's-
gambling, sex, and paying attention to that stuff too is just what I keep in my mind. And I remind people of that. They don't want to hear that, but I remind people, like, man, this you're going down a road. It's not good. I got this. Okay. You got it. Let me know when you
To
don't.
that same extent, if you now start putting harm reduction into that whole model.
Yeah.
Do you think that then increases the chance that that person one day does have that awakening? They start to feel that love that is harm reduction, that somebody cares about me, even though I know I'm doing something I'm not proud of or that I want to change, but I'm not ready to do it yet. Maybe Cameron, you can talk a little bit about the patients that you've seen and have they changed in the time that you've worked with them? Have some maybe had some improvements in their life? It could be, being able to hold down a job or getting custody of their kids back. And it all kind of starts with somebody being there to listen, to say hello, to say good morning.
Yeah, I mean, there's definitely folks that I've seen like stabilize in their use, decrease use, cease use. And that's always like, as a lot of folks here have said, that's always like what we hope is the goal, but it doesn't need to be the goal, being there for them on the human level is really all that matters. And when, as a lot of folks have said here and you as well, that, when a person, like people don't recover in a vacuum, they don't recover when like there's nothing there. We have you know, the definition of a substance use disorder, you know, is you use drugs despite negative consequences. And then we throw as many negative consequences at them as we possibly can and expect them to stop using drugs. And, you know, and then we're like years later, you know, we're like, why is this not working? And I think harm reduction is like the reverse of that, you know, it's that I love you regardless of your decisions. I'm not here to shove recovery down your throat. I'm here for you for the entire, you know, process of whatever that looks like. And let's be there and do it together. And that's where people start to maybe feel a little bit better about themselves, to feel the slightest bit more that like their life matters, that, you know, what's going to happen to them next matters, because if that person cares about me, then, you know, maybe I can care a little bit more about myself. And I've heard Liz say that, you know, many times, is that. And so I have seen folks like start to do well, but like I'll touch back on that original point from when I like opened up when we spoke, is that like, you know, I've had folks say that they feel better about themselves as a human being for the fact that they engage in our services. And I don't think that that's like a light matter, you know? A person that like felt completely down about themselves as a person, you know, just by simply engaging in a service where we're offering them like autonomy and things to better their health, they like feel like a human being again, you know? And that's when recovery has the possibility of happening.
I think what struck me the most with when I met you in Torrington was that, one, I loved seeing there were patients who came in and just said hi to you. They didn't want any of the stuff. They just wanted to say hello. You'd built that relationship with them. And there were also some who had gotten their use, you know, to a point where they were kind of in sustained recovery, but they were helping out their friends who weren't quite there yet. And they were coming to you and getting the stuff that you had to give to others in need. So you can kind of see that even if you can't get through to the person, maybe you're inadvertently getting through and you're humanizing it. And that's really what we're doing with this conversation too, is humanizing the conversation, whether it be thinking about it medically, thinking about it politically, thinking about it personally. There's a way to just break it down and see that it is a human underneath all of that. With that, I want to open up to the public because it's almost 7:15, so I want to give time for folks to ask questions in the audience, and then also if anybody's in the chat as well. Jeff, I saw your hand go up.
Just something that you said, Jerry, and you're talking about relationships. We know the research says relationships change more than anything else with somebody that we have a say in. About 30% of intentional change comes simply from a relationship. Sam Diaz, who was here, talked about serendipitously, but people go to the Overdose Prevention Center, they use lips because they're involved in conversations with people, they're doing their laundry, they're doing whatever it is. And I think that we forget that by the relationship is just someone coming saying hello, because maybe they're going to say more to you. And so we complicate things with techniques and with, trying to put research into play and without doing the most simple thing, form a therapeutic relationship with somebody by just accepting them where they're at, instead of saying, well, you need to be where I'm at for me to value what you're saying. It's simply brilliant. And I think it gets lost in the field.
Hi, I'm Brian. I'm a recovery support specialist for Rushford, Middletown. Harm reduction is something, I work in the detox unit, and I'm from Middletown, and I've been going to Main Street, Middletown, excuse me, on Wednesdays for the village brings their harm reduction van down. And I come down to the city or the north end of Middletown, and the change since they've been coming there has been just amazing. I come down and give them pamphlets and tell them about Rushford, trying to get them to come in when they're struggling. Excuse me, because I know a lot of the people that hang out in that area. So I think with the Root Center coming, a lot of our clients are going to be coming to you guys to get their methadone and stuff too. I think it's going to be tremendous help, so they don't have to take rides to Hartford to Britain, find rides or even skip, and then it's back to the using. So I think with this harm reduction stuff, I think it needs to be done and talked about a lot more than, these panels need to be going out until where the people in the city know more about it, because they're quick to judge, oh, that's the north end of Middletown, that's where they all hang out at, just leave them there. You know, where people start noticing and realizing how much it's helping, they might get more involved, so.
And then since you're talking about Middletown, we might as well just, Mayor, what are your thoughts when you hear that?
Well, my first thought is I'm very glad that you were here because you talked about that much better than I could, having been the person who was involved in helping make it possible. That I was gonna mention the village van and some of the harm reduction initiatives that have happened in Middletown over the years. There was you might have worked with them as well, but there was a couple of Wesleyan students who they were students when I was in office, and they were also EMTs working in the region, and just saw the need for this and started working with Community Health Center, with some of the other, with St. Vincent de Paul, which is the local soup kitchen and food pantry, which is where the village van parks. It really is in many ways, it's the hub for a lot of these services. And it makes me, first of all, really gratified to hear how much of an impact it has had. It's interesting because I tend to always agree that, like, the more awareness, the better. We've got to get the word out. We've got to share the data. We've got to share the success stories. I think that is really, really important. But the other side of the coin I was thinking about earlier is it's almost, and I would be interested to hear more, and we'll have to talk offline about just sort of what you're hearing on the negative side versus what you're hearing on the positive side. But it's in many ways, if it's working, it's almost like, just let it work, you know? And if the people who know about it are finding out about it, then that's a good thing. And I say that only because, you know, the more that we try to correct what has been a historic wrong in not having harm reduction as part of this, you know, portfolio, you know, it's people get addicted for different reasons. People have people struggle for different reasons. They're going to recover in different ways. And right to the point that's been made repeatedly up here, people are going to seek it out, and when they're ready for it, they're going to stick to it when they're ready for it. And oftentimes that is a matter of finding the right entry point, because it is very different for different people. And so as we try to fold it in with methadone and with AA and with all these other things, it maybe is sort of best to just treat it as another part of the solution as best we can, you know, and to reduce that stigma and that discriminatory attitude of you know, and you're just being an enabler. I think I'm really, again, gratified that in Middletown we are able to do this type of thing without getting a ton of heat, because I know that wouldn't be true in other communities in this state and in other communities around the country. And it's just, but again, it's sort of this interesting thing about Connecticut and the way that we run services and administer services, that we were having harm reduction services underway. And this dates back even further with Community Health Center and other programs, all along while having this zoning thing that banned methadone clinics. And, you know, it's like you start from a premise. I start from the premise that if I had faith that prohibition was effective, then I would think that alcohol should clearly be illegal, because it is such a public health menace. But we know that it is not effective. It's not effective with alcohol. It's not effective. We know we have to start from the premise that this is a factor in our society and in our community, and it's a factor for more and more people. And I don't know. I think that what is going to work is when you start to see exactly what you said, that the clients at the harm reduction van are going to start to become, not all of them, but not immediately necessarily, but they'll start to become clients at the Root Center, or they'll start to become involved in something else positive, hopefully in Middletown. And that's going to lead to good results. And more people are going to say what you just said, is that I look at the North End, I look at these neighborhoods, and I see something totally different than what I used to associate with it. So that's my reaction.
Stephen, I have a question for Dr.
Oh, yeah, just a comment and a question. First of all, thank you so much for coming today. I know you had a very, very long trip.
It's okay.
I appreciate that. And as people know, people are on the panel, there's no reimbursement. They're just here because they want to talk about the work. So I read about you, and I know Jeffrey reads about you on LinkedIn constantly. The work that you're doing down in Kensington is pretty amazing. Your podcast was fantastic with Margo. You and Sarah Laurel of Savage Sisters. If you haven't seen the podcast that Ruth has done with both of them, certainly take a look, because these two are amazing individuals. With all that's going on in Kensington, really being the front lines of where it's the worst of the worst, what can you recommend from your experience over there that we can take away today to try to do that?
That's a great question. Right now, Kensington isn't in a very good place, even though some people may think that it is. So I think just the fact that you have your mayor here is huge,
Yeah.
because that type of support for harm reduction is not the case in Philadelphia County. In some of the suburbs, it's a little bit better, but I think the fact that it seems here and coming here, it's refreshing that there's more of an all hands on deck approach where you have, political, figures involved. You have folks on the education side, you have providers kind of all literally coming to the table to talk. In the Philadelphia area, that's not the case. There's not a lot of talking. There's not a lot of collaboration. It's very much everyone, depending on what discipline they're from, are digging in their heels and saying, this is the way it should be done. So as a result, who suffers? The people who suffer are the people in active addiction that aren't ready yet, but are now missing out on harm reduction services that are helping, not to put such a task on the system. The family members of those people are suffering, and then the community around is also suffering. So I think, one of the things that you can do is just keep doing what you're doing, because right now the approach that has been implemented in Kensington is not working, so much so to where Savage Sisters will not be on Kensington Avenue anymore. They actually have lost their lease, and they relocated to another part of the city. So what's happened is they had a cleanup, and it was national news, and they talked about going down to the avenue, and they covered like such a small radius and basically said, hey, this area is going to be cleaned up. And they put signs up that gave people, I think they said 30 days. If you go down to that neighborhood, you'll see that people are living on the streets. They have tents, or they're just kind of hanging out on the streets because they're displaced. And what happened was the day of enforcement came, and they were told to leave, that they couldn't be there. What was supposed to happen was an offer of treatment. Again, an offer of treatment for somebody who doesn't want treatment, that's not going to work. The other alternative was jail. Was basically saying you're gonna be put in jail. So that's kind of where they are. It's a little archaic. It's a lot archaic, and it's not working. And they're gonna see that that's not working. So where do those people go that say that I don't want treatment, or that have evaded the police? They're just moving to different streets in the neighborhood, and they're also going to different sections of the city. So yes, Kensington Avenue may not be an eyesore, or which people call it, for the past month, but it's not, there hasn't been an initiative to actually help. So I think what you're doing here is, I wish everybody from the city of Philadelphia would come here and hang out and see what you guys are doing.
So collaboration really is,
That's
any
number
levels
one.
as you can get is the key.
Yeah, there's a lot of this. Everybody wants to be heard, but nobody wants to listen.
I can't be overemphasized. I don't want to take up too much time, but I think I appreciate you
Yeah.
saying that. And I think for all of our challenges in Connecticut, I said land of steady habits earlier, but we really have, I keep seeing these parallels to the approach that the state has taken to housing, and the approach that we're trying to take in Middletown to housing, where, this is a very expensive place to live, and that's one of the biggest challenges that we face as a state, but we do not have the homelessness problem that a lot of other, cities or urban areas have. It's not to say we don't have challenges, but the state has come a hugely long way in the last 10 to 20 years by investing in housing resources and by creating these coordinated access networks where everybody is coming in through one pipe. Everybody who's looking for housing, seeking housing, comes in through one pipeline. They're redirected to the regional coordinated access network. Everybody is sort of was at first forced, and now realize, oh, this works better. People are getting housed and getting the type of housing that they need based on what the need is. The other parallel that I see is that we also have to take a harm reduction approach to housing, because there is a population who is not going to accept shelter housing, who is not going to accept supportive housing, who is just not in a place where that's gonna end up. Obviously, that is 99 times out of 100 co-occurring with substance use and mental health challenges. And so in Middletown, we operate a warming center, just an overnight warming center that is not technically under the laws, under the rules, a shelter because it doesn't have beds. But the question has to, again, come back to, do you want to have the person freeze to death, or do you want to do something to get them into a place where they have a roof over their head? And if the answer is the latter, you have to figure out a solution to that. And that, again, it's like, it is the hardest work that there is. And keeping it together and keeping people coordinated is the only way, that is the only thing, holding one another accountable, but also making sure that everybody who has the same interest is rowing in the same direction. Otherwise, nobody could survive doing this work,
Well, and I think where you're also, it seems like there's a lot of dollars that have to be put out, right? And I think we always go back to how much is something going to cost, and then that can always be an indication of whether it's gonna proceed or whether it's gonna die in its tracks. And Sarita and Ben, if maybe you guys can speak a little bit more to what the cost is from the medical side. You touched on it a little bit before, but if we implement harm reduction, if we implement these services, then by default, a lot of these costs are going to go down, because the cost of not offering somebody a chance to recover in whatever that means for them, it might not be full, abstaining from use entirely, but whatever it means for them, in some sense, that's gotta save, and I use that loosely, but save the dollars that some people might be, they don't want to use for certain things, but they end up using when they don't give harm reduction. When you're not going to give the money to help somebody recover, well, the money's gonna go somewhere else when EMS gets called and police get called and fire get dispatched and they go to the ER, and the dollars are there, it's happening. It's just how do we want to, disperse them?
Well, as doctors, we're not actually experts in healthcare finance. That question would be better answered by Steve here, who has, worked.
Well, in terms of just stopping things
Yeah,
before they
yeah,
get
yeah.
to a certain
But
point.
I think what I was sort of saying earlier is that, of course, there's a humanistic perspective and a healthcare perspective. Like, why would you want a huge section of the population to suffer from endocarditis or, hepatitis C or HIV or, staphylococcal skin infections or whatever they might be? Because not only are they themselves suffering, but they also kind of then are out of the workforce. They might become permanently disabled. Either way, you're taking an entire section of the population and you're saying, because they're actively using, alcohol or drugs, they should just become sick, and sort of sometimes with things that can't be reversed. So that's one thing. But it's sort of parallel to the argument of people who say that they don't want everybody to have health insurance, right? Because they're like, well, we don't want to pay for it. But you're already paying for it, because hospitals they're required legally that if somebody comes to the emergency room, then they have to be treated. And if they really need to be admitted and hospitalized, or that it's not possible to discharge them because of their medical condition, then they get admitted to the hospital. Let's say they have no insurance. That money is ultimately passed along to private insurance companies like that many of us are insured through, and then our premiums go up, and that's how those dollars are made up. Besides the government, we're talking about people who don't even have Medicaid. Or even if you take public sector insurance, sometimes the amount they pay is less than what the cost of the service is. So that's also underwritten unofficially by most people don't even stop to think about that. The kind of people that you're talking about who are like, well, let them just die on the side of the road, right? They're often people who have secure health insurance, and they're like, my taxes are going to go up. Well, you're already paying for that, aside from the humanistic aspect. And you will be continuing to pay for them for like 20 years, 15 years, if they get these illnesses, besides the cost of the acute hospitalization.
I think there's a parallel to be made too, going back to the point about the parallels with housing. That's something we
Mhm.
see a lot too in psychiatry, is that like just patients coming in repeatedly, they certainly have some mental health concerns, but a big part of why they're presenting repeatedly is they need somewhere to live. And we all know that's using up resources, and ultimately it might be cheaper for everyone to just have an easier way to actually give them somewhere to live. And I think a lot of people know that, and that doesn't, immediately materialize into any kind of solution, but I just wanted to note that's another parallel, I think, is that
I mean, it's a lot of it is perception. It has to come from it has to come from the residents of a particular state or country and sort of rise up rather than going, top down. I think for any of these things, whether it's housing, harm reduction, warming centers, whatever it might be, because if people think it's somebody else's problem, but ultimately you are going to be dealing with it somehow in terms of like crime or whatever else, money. And money's not just in healthcare dollars, it's also lost productivity. And that's an argument for people who are not looking at the humanistic side of things. Like there are people that no matter what you tell them, they are convinced that if you have a substance use disorder, then anything that happens to you is your problem. And yes, that it absolutely includes healthcare professionals, like I said earlier. Yeah, there's a lot of stigma within the healthcare system.
Yes.
So, I'm persuaded. I'm sold. And it sounds like there's, bits and pieces happening at the local level. What's happening at the state, federal level? You think, we kind of blundered our way through the pandemic, but we wouldn't have gotten where we did get without a lot of state, federal funding. What's happening at the state level?
Ben.
Anybody else have a good answer?
I could say something.
Yeah.
I could say that the federal government and the state governments are spending an incredible amount of money to try and kind of stem the tide of overdose deaths.
Yes.
And they've been spending this money for like probably a decade. And really there has not been much of a dent.
Nope.
So the preliminary data, it's subject to change. I almost don't want to say it, not because the preliminary data for 2023 shows that there might be a small dip in Connecticut, but it's preliminary. It could change tomorrow. And also, if you look at it over a period of like even the last 4 or 5 years, if you look at the map and you show it to a statistician, I'm not a statistician, it's not some giant difference. It goes up, it goes down, but literally a huge amount of money is being spent from the CDC, from SAMHSA. It goes to all the different states and union territories. It's not being frittered away. People are spending it on naloxone distribution, needle exchange, a variety of things. The CDC is much more interested now in like peer recovery counselors and things like that, people with lived experience. But none of this has actually slowed in any kind of like really significant manner, the number of overdose deaths.
I just wanted to add to that, I just want to say the illicit drug market is not, it's a different ballgame. And it has been, I would say, at least in some Northeast states for the past decade. So when, we're saying it hasn't made a dent, there's a couple of reasons. One is we're doing more of the same. Let's just get more rehabs and more beds. Well, that's not necessarily the answer. It depends on the level of care and what the person needs. To everyone's point, it may not be a rehab. Rehab is sometimes an escape for people to get warm when it's cold out for 30 days. They're looking for their basic needs to be met through rehab and come up for air temporarily. So, the answer is we have to, I think, that we have to do a better job of being more progressive and open-minded with the funds that are coming down. We have all these opioid abatement monies coming down. And I sit with different states about grants that we can do. And I'm like literally standing on my head, like being like, hey, can we do this? Can we do this? Can we do this? And the amount of discomfort, and it's not fair, I think, to people that hold political office, seats, because we expect them to be experts on this disease space. And you have 20 million different people coming at you for all different things. And they're being tasked with making the decision for these, these funds that are coming down. And it's not fair because I feel like, arming folks like this with the proper experts can be helpful so that we can feel more comfortable or somebody, at a state level can feel more comfortable doing something different instead of heads in beds because they sat down and they have a board or a group of people that can help them. I think more education is really important, and surrounding the people that are making the decisions that have been unfortunately tasked with making these decisions, helping them out, I think is something that could be needed because it will it'll make you feel more confident and the constituents feel more confident about what's happening, instead of just doing more of the same because we're uncomfortable. So I think that's something that we could do a better job in, is just, appropriate education, making people feel more comfortable in order to spend the monies in different new progressive ways. We may not have the research that shows that it helps yet, but anecdotally, we know that other levels of care can help, not just more heads in beds.
I would add to that, the state is very behind harm reduction, or at least DEMIS is, the Department of Mental Health and Addiction Services. And they have a ton of different committees, one of which is the treatment subcommittee, and they have supported harm reduction and have people who are making decisions on the big advisory committee around how state settlement funds are being spent, who are very supportive of harm reduction. But the lion's share of what people want money to be spent on is treatment. And so it's an optics thing, which is we come back to public perception and why we're all here. And this conversation about we need to raise the playing field, that the knowledge level among everybody in our communities, so that your sister knows about it. And so your mom knows about it, not just people who are in the know, who are in the business, who come to talks like, we need to spread the word, talk about it, get it into the public consciousness. Because right now in the DNA in America is this notion, it's either one or the other. You're either addicted or you're not addicted. And this whole space that we're trying to talk about advancing knowledge on is like, really, we're behind in our general awareness, right? So we got to come up and we got to talk about it more. But I would say at the state level, they're waiting for that leadership from our communities to take the balls to open, say, an overdose prevention center. Because we had Senator Anwar last year pass a bill, but it didn't pass because the commissioner said, until the federal laws change, I think we should do this. But they're behind it, like they think it's a good idea. They're just scared, like no one's gonna stick their neck out. But if the public consensus was people are worried that if they don't do it, they're gonna lose their seat, then it's gonna happen. But we gotta talk about it and make it so everybody actually thinks this is urgent, it matters, it's the right thing to do.
Do you want to add anything to that?
I think it's all great comments. I think that the recovery coach model from the federal government, Senator Murphy was very involved in bringing that forward when I was in that office. And I think that is a huge step in the right direction towards acknowledging, again, just like what actually works and what has been proven to work, and and to your point about sometimes cost effectiveness is the tool to use to sell the audience, and the proof is there. But I think it's just a matter of matching the scale of the challenge. Like we are benefiting from, Middletown has received ARPA dollars that we have used some of to put towards recovery efforts. We are among the beneficiaries, along with all the other towns in the state, I think, of settlement dollars from some, still some lawsuits pending that we are again using to support some of these initiatives that we've talked about tonight. But it's the question of trying to match the scale of the problem. And I totally agree. I think it is going to take it's going to take leadership to step out and say it. And I think I think hopefully Middletown can be, a model of success. In some ways, it will be a model of the challenges that are experienced, and we need to just tell the positive stories. To the point that you were making, I think the one thing that I admire a lot about our governor, and a lot of people I think admire a lot about Governor Lamont is in his handling of the COVID-19 pandemic. He took this big sort of step back. And if you watch the press conferences that are like seared into some of our memories, he took a big step back and deferred to professionals and experts, both in state government and at healthcare institutions and behavioral health institutions, and the chambers of commerce when it came to impact on local businesses. And unlike a lot of politicians, was not looking to sort of steer debate over whether the pandemic was or wasn't this, or what you should do, culture war, bullshit, whatever. Like you saw somebody, and again, we were experiencing this in real time, like, oh my God, the sky is falling, and it felt like nobody kind of really knew what they were doing, ourselves included, and we were having to respond urgently anyway. But now with the benefit of a little bit of hindsight, it really is, I took a lot of cues from him, and I think other local leaders succeeded or failed based on whether they did the same thing. And that is just unfortunately a rare thing. It's unfortunately an exceedingly rare thing. And it takes courage to be able to do that.
Anyone else have any other questions?
Yes.
Going back to your comment, you have to wait for people to be ready. You can't push it, which makes sense. No one likes to be pushed. What do you see as the inhibitors from that readiness? Is it a biological thing, or what's the tipping point when they actually get to that point of readiness?
That's a really big question. I think as far as the inhibitors goes, it's different for everyone. What is preventing someone from getting help, if you just look at it psychologically, and if you want to generalize it a little bit, is you can be on the outside and you can look at somebody who's struggling in active addiction, and you can say, how can they do that? Like, how can they be homeless, or how can they be selling their body, or how can they, put themselves in constant danger and harm and lose their home? And like, how can they, you look at it from the outside and say, how can you do this? But when you look at addiction, you have to look at also what's happening neurologically, because it's a neurobiological midbrain disease. And, even though, if you're thinking, wow, how can you do this to yourself? The brain, the limbic system, the mid part of the brain that's responsible for impulse and reward, is driving the car, not the prefrontal cortex, which is the good decision making. The compulsion to use and the need to use outweighs any other thing that you think would be important to the average individual. So you're competing with what's happening, neurologically in the brain. So I think that's one of the big things. The other part of your question was,
If that's it, what point do those people tip and then say they're ready?
yeah, and then you'll hear things in the rooms, people who participate in 12-step fellowships, everybody's bottom is different. I don't necessarily, that language is fine, but you don't know. There's not a crystal ball where I can be like, okay, well, for my own personal family, I was like, this is going to be the time. Like, I know, and it wasn't. And I don't know what it could be, because it's 70 degrees and sunny, and that's the time. We can't predict, when somebody's going to have had enough. The other thing that I think we do, and we do this in the behavioral health world, is we separate drugs and alcohol from mental health concerns. They are all in the same book. It's called the DSM, right? It's the Diagnostic Statistical Manual for Psychiatric Disorders. It's all in the same thing, but that's part of the stigma of the disease. So OUD or alcohol or meth, that may be one thing that they're struggling with. There's other mental health concerns that are typically happening, whether it's depression, unaddressed trauma, undiagnosed or not properly medicated bipolar disorder. So there's so many other things happening with these folks that, the addiction and what's driving that is one component that could be inhibiting their ability to want to, move forward and get better.
Can I comment on what Bill asked? And Bill's a board member too, so thank him for being here. You know what it is, from my perspective, I think with your question, I think we overanalyze it when it's addiction. Because you know what, if it's a diabetic, would you be asking that same question? What's the tipping point when they're gonna stop eating that cake, or that fifth cake, or that fourth bowl of ice cream? But we think about it differently when it's addiction. I think that goes to part of the stigma as well. We wouldn't ask that for the person's on insulin every day, and still 5 cakes a day, not getting off their couch, so on and so on. But we think about that from addiction. So I don't think there's a clear-cut answer. I agree with Dr. Otter, but that's part of the issue. We wouldn't be saying that about a different disease, but we say that and ask those questions about addiction.
And I think, to be totally honest, behind closed doors in the healthcare world, I don't know if Ben would agree or disagree with me. I mean, if somebody comes in and they're like obese and they're suffering from diabetes, or they're being admitted for their second MI, there is a certain amount of stigma against that as well, why aren't they making the lifestyle changes? But it's much magnified, I agree with you, when it comes to somebody with an addictive illness. Yeah, absolutely. Much magnified.
When are they gonna flip over? When is it gonna change?
Yeah,
When are they
yeah.
gonna stop? What's gonna be that point in time?
But at least people are nicer up front to the person who's come in with a third heart attack and is still eating,
Yes,
like,
yes,
they're,
yes.
they're a little bit more polite up front but they do have those discussions.
I
They
think
don't,
that-
they don't,
While
they
eating the
don't kick
cake.
them out of the hospital.
No,
And,
exactly.
and in reality, when it comes to this type of stuff.
Yeah, yeah,
you know,
exactly.
They're kicked out in a lot of circumstances.
It is just, and it's all a matter of, it's a spectrum, right? But I do think it's an interesting comparison too, because I was gonna say before, I think part of the challenge is that we are just kind of an addictive culture, like we're kind of addicted to addictions and, sugar is addictive, right? Like, that's not the cause of everybody's diabetes, it's not the cause of everybody's obesity, but it is a huge problem, is that we are learning more and more about, the addictive nature of the way that we have organized our lives around these substances and these experiences and these, ways of, I guess, changing our interactions with the world, and with other people. And, it's, you use the term, I think, transfer addictions. It's like, there's always gonna be, it could be anything from, drugs and alcohol to religious fervor to, work or sex, it's mentioned. It's like, that is part of being human and accepting that as part of the human experience. And like, the question then becomes, what do we do to fix that? And, not to get all philosophical, but like, it's important that we be working together to solve problems, because that's what fills it, I think. But anyway.
Yes.
Yeah.
I'm just wondering if there's any advice. So I think a lot of the people in the room right now have been in the field for a while and have kind of navigated some of these challenges of transitioning from being new to kind of being veterans and understanding the patience that needs to go into this. I'm wondering if there's any advice for folks who are newer in the field that are coming in, because I do think that there is a big generational difference in the way that we're treating addiction as opposed to the way that we treated it even 10 years ago. And I'm just wondering, from your perspective, are there any words of advice that you would offer to folks that are entering the field at this point?
Yeah, therapy. Get your own. Get your own therapy, take care of yourself, because, you can get burned out really easily. And that's what I do for myself. And I'll say this, but like, not like I follow it myself all the time. Try not to take everything personal. Cause if it's a personal indictment every time somebody relapses, then you're gonna do a number on yourself and your own mental health. So I think therapy, it's a long game, it's a marathon. And just reminding yourself of that. And to your point earlier, it's the little wins. I could see 25 people in a day or whatever. And if I hear that through the grapevine, that one person out of those 25 just had a small success, they got a job. Small success for some people, huge for them. Like, that's like, all right, cool. Like, it makes me feel good to know that they got benefit from the treatment that they engaged in. So for me, it's just all about therapy, taking care of yourself, and also having a group. Like, if you're new and you're working with a cohort of people, make sure they have the same sick, dark sense of humor that you do. Because no offense to the younger generations out there, but like, everybody gets offended. Like, I'm gonna come off like from the side with some dark humor or some like stuff that may offend you, but I need to survive.
Yes.
So if you can't handle it, like, if this ain't your thing, then you shouldn't be in the addiction field anyway, because they're the realest group of people ever. And the clients can read you in 2 seconds. They know you better than you know yourself in 2 minutes, because they have a really good intuition. And a lot of people dismiss that. But I think it's definitely getting your own therapy and taking care of yourself so you don't burn out.
They ain't seen nothing. We could have had Sarah here tonight.
Oh yeah, if you had Sarah, if you think I'm a little street, like, I've tucked mine in.
Yeah.
Sarah, no, she has to take the etiquette course still. No, yeah.
Whether it's in a group of people or in a conversation, she
Exactly.
lets it rip.
Yep.
She's worth following.
Anybody else? Yes.
Just more of a general comment. I really appreciated, some of the people that shared on, their lived experience with loved ones in recovery and, or who had been through the process and struggled, themselves, you know, and I just wanted to point out, like, a lot of the origins of harm reduction, were peer-based initiatives. And so one of the things that just really drives me is the incorporation of peer services within, our treatment programs. And there is still a lot of, I think, fear even around that and how to incorporate it properly into the system to allow peers to do peer support. We've been trying in the state of Connecticut to get peer-based respite, peer-run respite here. And like some of the earlier attempts at that had some, you know, I wanted to have clinical oversight. And I believe we're finally successful in moving something forward where that's going to be opening up soon. And, you know, so these are some things that take time. You know, and the education piece is really important because this is a cultural thing, you know, and if you look at all the stuff that we've already incorporated harm reduction into our lives, we wear seatbelts, we wear helmets, you know, there's birth control. I mean, there's a lot of things that, you know, we take for granted that are harm reduction, you know, and you look at the resistance that happened with some of that moving forward and then how readily accepted they are today. So, you know, there is this growing pain that we have to go through, but this is the way that we move on past that. You know, so I'm just really grateful for those of you that shared on that side of it. Thank you.
Well, I want to allow everybody some time to get some food and mingle. Oh, but there's one more.
Yes,
Sorry, I'm behind
yes,
the
no
wall.
worry, you're right behind the pole there.
I want to try to make this a question. It's really hard not to editorialize as well. But having started in the field and from an abstinence base, and then now doing it for a long time, you know, accepting harm reduction, but also working with professionals, I see that there has to be some kind of paradigm shift. And I don't know if that's happening across the board, because especially the medical field, and I'm working also with first responders. There's compassion fatigue. There's when the opioid crisis first started, the blame was put on the physicians for giving the prescriptions out. At the same time, if someone became addicted, they passed off the patient to someone else. It wasn't their thing, so the separation. And I've asked how many hours are put in for any of the helping professions on learning about the origins of addiction and counteracting stigma, and like you're saying, getting help for themselves. So do you see anything happening on that end from any of your experiences, that there's more happening to support the people that enable the change, that help people?
Are you talking about like education for healthcare professionals during their learning years and even later on when they're in practice?
Correct.
Well, the CDC funded a very large, you know, they funded this big thing. It's part of their Overdose to Action, OD2A. And they sent money to all the states and union territories. A chunk of that money that came to Connecticut was actually given to UConn by Department of Public Health. And I was part of a group with our CCPC, Connecticut Comprehensive Pain Center. We do multiple things, but so there are two internists with a lot of experience in pain management and, you know, knowledge about substance use disorders. There's me as the addiction psychiatrist. There's pharmacist who's actually the head of our pharmacy services. But anyway, basically the CDC funded us to do a 6-part web-based series because it was during COVID. And the web-based actually worked because more people could come, just like people are joining on Zoom here. So basically they funded similar programs across all the states, everywhere across the country. It was a huge amount of money that when you add up all the different states. So basically we did a 6-part series on pain management, evidence-based pain management. This doesn't mean you never give anybody opioids, right? Including that was substance use disorders, that gray zone between, you know, developing an actual substance use disorder and just misuse. So ours was very successful. Actually, I have to say we were the most successful across the country because it was just supposed to be Connecticut, but we had people who attended from 12 states and 1 North African country. And it's interesting because we still hear now that, you know, you don't need to educate healthcare professionals anymore, like people who prescribe, for instance, doctors, nurse practitioners, physicians assistants, because the whole the whole epidemic has now moved to like fentanyl, xylazine, but you still need to educate them. Like the DEA is still shutting down practices. And so anyway, it was very successful. And as a result of that, we didn't measure the patients who were in private insurance because Medicaid gave us the data for the Medicaid patients. And the MME, which is the morphine milli equivalence for the Medicaid patients, I'm sure it was, I imagine it was for others as well, but we didn't have the data on them, went down quite a bit. It went down below the 90 MME, which is actually no longer being enforced by the CDC or recommended. But so that was for people who are already in practice, right? But part of it was also shifting. A part of it was how to have difficult conversations with your patients when, you know, you need to say, you don't really need an opioid for this, that sort of thing. How to have difficult conversations if you're referring them to like treatment. And then as far as the trainees go, like in any specialty, whether it's psychiatry, internal medicine, surgery, whatever it might be, honestly, the amount of training for addiction medicine or addiction psychiatry is minimal as the requirement. So like the Yukon psychiatry program actually stands out, but it's because our program has been run by addiction psychiatrists for like 15 years now. It was Dr. John Cobalt before me, who's a research scientist in alcoholism, and then it's me. So obviously we have like, we're kind of a poster child program with a lot of training, which I won't get into, but in like, for instance, if you look at just psychiatry residencies, 4 years of training after medical school, and the requirement is just 4 weeks for addiction psychiatry. That's like nothing. And we have a lot more, but you know. So there is a lot of funding from federal government, is what I was trying to say. Has not made a dent in the overdose deaths.
Still trying to get here.
We could start a whole nother forum on that topic, so.
Thank you so much to our panelists. I want to give time to everybody to be able to eat and mingle with our panelists and speak amongst yourselves, but thank you so much for coming. As you could hear tonight, really what was reiterated more than once was that it starts kind of from the bottom and it builds up, right? We have to be the ones to make the noise. We have to be the ones to have the conversations. So it really means a lot when we can get folks with your expertise to come in and then folks like you guys to also attend. It just gets that conversation going.